Good morning, ladies and gentlemen. I'm Dr. Sini Sukojo, your MC for today. Welcome to the 11th National Myeloma Forum 2021, a webinar organized by the National University Cancer Institute Singapore, Singapore General Hospital, and Tan Tock Seng Hospital. Today, our experts will be sharing with you on the increasing importance of supportive care in myeloma treatment, what are the common complications of myeloma, and what patients who are transplant ineligible can expect in terms of treatment. We'll also be touching on COVID-19, the risk it means for myeloma patients, and the effects of vaccination. For those who are joining us for the first time, NCIS is a national specialist center under the National University Health System NUHS. It is the only public cancer center in Singapore that treats both pediatric and adult cancer patients through its facilities located at the National University Hospital. NCIS also provides cancer services to partners like the Ng Teng Fong General Hospital, Alexandra Hospital, Jurong Medical Center, and Tan Tock Seng Hospital, and extends services to patients at home and in the community. Our comprehensive and personalized services includes screening, diagnosis, treatment, and supportive care. We have an exciting lineup of speakers today. And before we start, I would like to extend our gratitude to our sponsor, Amgen Biotechnology Singapore, for their generous support towards this event. Before we begin, please kindly note the following. Your microphone has been muted by default. You can type your questions inside the Q&A box, and our specialists will answer them during the live Q&A sessions. You have a question for a specific speaker, you can address your question to him or her by indicating so in the Q&A box. Lastly, we will greatly appreciate if you can take 2 to 3 minutes of your time to fill up the feedback form at the end of this webinar. Thank you. Now, without further ado, please let us welcome Professor Chng, Director of NCIS, to give the opening speech. Professor Chng, please.
Thanks very much, Sini, and good morning to everyone who is on this webinar. It is very gratifying, despite these challenging times with the COVID and travel restriction, that we have such a lot of registrants for this event. I was told that today there is more than 400 people have registered. And this is one of the reasons why we have started a bit late, because it's taking us quite long to admit people, and people are still coming in to this call. And also we are having some participants from overseas as well. So it's kind of interesting to know that people are also interested outside of Singapore to find out how we're helping our patients and you know, what we're doing for myeloma patients in Singapore. This is the 11th year that we are doing this. So through thick and thin, we have never missed a single National Myeloma Patient Forum. The last 2 years during this COVID period, we have been able to do it via the webinar format. So clearly we miss meeting up face-to-face with our patients and having the opportunity to interact with them. But I think these virtual platforms have given us new opportunity to reach out to more people. So certainly during the times when we have physical meeting, we have never had so many participants in these types of meeting before. So, you know, I think there are a lot of positives to take away from this as well. And this is truly a national effort. And, you know, today on this webinar, we have representation from all the major hospitals that treat myeloma patients, both in the public and private sector. All our doctors have volunteered their time to do this because we truly believe and are passionate about helping our patients. Dr. Sini here is actually currently in the US, and this is, I think, night time for her. Even despite that, she had volunteered to be our MC for today. So I think, you know, this is our effort for our patients. And certainly these are very exciting times for myeloma patients because the treatment has already improved so much, but we still have a lot of exciting things that are emerging that will become available to our patients in the coming years. The outcomes is likely to continue to improve. The treatment are likely to be better, not just because they are more effective, but also they are better tolerated. And also our knowledge of supporting patients through treatment and so on will only continue to improve. And this will also help greatly. And you'll hear a lot about these topics in today's various presentation. And I think the other important thing that I would just want to close with is that we also feel that the movement is getting to a point where perhaps the patients can also do a lot more for themselves, can also start to develop an agenda that is important for patients and to provide better patient support, education, and advocacy about access to treatment, funding for treatment, and so on. And just last week, we have a very fruitful meeting with the International Myeloma Foundation, and we had a meeting where some of our patient leaders have met together with a patient support group in other Asian countries within the Asian Myeloma Network. And we have very interesting discussion and sharing. And I think there is good motivation and good impetus after that for us to develop a stronger patient support organization in Singapore with the help of International Myeloma Foundation. So this is also something that perhaps the community in Singapore can look forward to in the next 1 or 2 years as well. So a lot of exciting things that's happening. I think for today, the focus will be on some very important topic to educate our patients and to have discussion around these topics. So without much further ado, I will hand back to Cindy to introduce our very first speaker. Thank you very much and look forward to all of you enjoying a very fruitful webinar. Thank you.
Thank you, Professor Chng. Now, let us welcome our first speaker, Dr. Alison Soh, who is a senior consultant from the Department of Haematology at the Tan Tock Seng Hospital. Dr. Allison will share more on supportive care in multiple myeloma. Dr. Allison, please.
So good morning, everybody, and thank you for the kind introduction. Now, as new treatments are essentially converting myeloma into a form of chronic disease, it's important that we start to focus on effective supportive and symptomatic care to complement myeloma treatment, to alleviate complications, and to optimize quality of life at all stages of the disease, from diagnosis through the multiple relapses and to end of life. In the next 20 minutes, I'll give you a brief overview of the supportive care available for our myeloma patients. Now, there are many aspects of supportive care in myeloma, but it can be broadly divided into preventing and tackling the complications of myeloma disease itself, preventing and dealing with the side effects of the myeloma treatment, but not forgetting the very important psychosocial and emotional well-being of our patients and their families. Because symptoms that patients experience may be brought on by both the myeloma disease itself, as well as the treatment that we offer patients. And in order to support our patients in all these areas, we need a robust holistic needs assessment to identify areas that need to be focused on at different time points of the patient's journey, because these needs will change with time. So some of the common complications of myeloma and from some of the treatments may include anemia, which is low red blood count, bleeding, infections, bone pain and bone disease, and peripheral neuropathy, which is essentially pins and needles and numbness, tingling, experienced in the hands and feet of our patients. And other areas that are quite important to note includes the prevention and treatment of blood clots, rare complications of bisphosphonate treatment called osteonecrosis of the jaw, getting our patients back on their feet with physiotherapy, rehab, occupational therapists, especially for our patients who have been deconditioned due to pain or bone complication of myeloma, nutritional support from dietitians, psychological, emotional, and financial support, as well as end-of-life planning. Now, tackling all these issues require a multidisciplinary approach involving different specialties, including your hematologists, orthopedic surgeons, interventional radiologists, radiation oncologists, dental surgeons, psychologists, palliative care and pain team, as well as our clinical nurse specialists, physios, OTs, and medical social workers, to name a few. So I'll now move on to the more common complications experienced by our patients. So anemia, to start off with, the lack of red blood cells, can be multifactorial. We know that myeloma infiltrates the bone marrow, the factory of all our blood cells, and this can lead to a reduced production of red blood cells. But myeloma can also affect the kidneys, leading to reduced erythropoietin hormone production and therefore anemia. Some of the treatment that we offer patients may also have side effects of anemia as well. Of course, we need to exclude bleeding as well as vitamin deficiencies such as B12, folate, or iron, because they are essential in making red cells. Now, a quick fix solution is blood transfusion, and indeed some patients may need that occasionally, especially early on in the diagnosis. But often patients may notice that with effective myeloma treatment, getting rid of the myeloma cells in the bone marrow, they will start to make more blood and may become transfusion independent. It's important to check and supplement any vitamin deficiencies, otherwise it would be difficult for our marrow to respond and to produce more red cells. Erythropoietin can improve the hemoglobin level and the quality of life. And for patients who have a hemoglobin that is persistently lower than, for example, 10 and are symptomatic of their anemia, a trial of erythropoietin should be considered. And very generally, the hemoglobin does rise in around 2/3 of our patients, and thereby reducing transfusion needs. And in many other patients, they may not even need transfusions anymore. So coming to bleeding and bruising, again, the marrow can be infiltrated by myeloma in a degree to lead to a lower platelet count. The cells, these platelets are cells that help us form a blood clot and stop us from bleeding. But less often, myeloma can also cause abnormalities in the coagulation system, another system that's needed to stop us from bleeding. Again, we do see that with treatment of myeloma, the platelet count can also improve, especially in those with heavy bone marrow infiltration by the disease. Bleeding and bruising can also be a result of the side effects of certain myeloma treatment. For example, bortezomib or Velcade, lenalidomide, pomalidomide, to name a few, can cause a degree of low platelet count. Long-term steroids can also lead to skin thinning and easy bruising. And aspirin and heparin used to prevent blood clots can also lead to easy bleeding as well. So again, depending on the underlying cause of the bleeding, there may also be a need to, at least temporarily, transfuse platelets or other blood products. We may also need to dose adjust some of the myeloma treatment, or even switching or temporarily withholding certain medications. Now, infections and low white cell count, these are important things to think about. And our myeloma patients have an increased tendency towards getting infections, especially in the beginning of the diagnosis. And this is a result of A, bone marrow infiltration, B, the reduced immune defense associated with myeloma, we call it hypogammaglobulinemia, and C, treatment-related side effects leading to low white cell count and low neutrophils, we call neutropenia. We can support patients with a two-pronged approach. First, prevention of infections with prophylactic antimicrobials and vaccinations, and B, treatment of established infections. For the prevention part, we can encourage our patients to be vaccinated appropriately, including the seasonal flu vaccine, pneumococcal, Haemophilus influenzae, following revaccination schedule after stem cell transplantation, and of course the COVID-19 vaccines that Professor Chng is going to talk to you about later on. And for selected patients with certain myeloma treatment, we can also offer them G-CSF injections, such as filgrastim, to boost the number of white cells temporarily. We often start our patients on acyclovir to prevent reactivation of herpes virus, and this is most important for patients on proteasome inhibitors such as Velcade, ixazomib, or carfilzomib, those who have undergone stem cell transplantation, and those with recurrent herpes reactivation. We also give prophylaxis against PCP, pneumocystis carinii pneumonia infection, especially those on high-dose steroids in the form of either Bactrim tablets or pentamidine nebulizers. And for patients with previous hepatitis B infections, we give prophylaxis such as entecavir to prevent reactivation of hepatitis. Now, on the treatment side, it really depends on what infection the patient has, and we will give appropriate antimicrobials accordingly. But for patients with recurrent bacterial infections, for example, 3 or more infections a year needing treatment, and those patients have low immunoglobulins and have already failed a trial of prophylactic antibiotics, they may benefit from monthly infusions of intravenous immunoglobulins. Because of limited time, I'll just mention a couple of more common complications of myeloma, and Dr. Chandramouli will elaborate more in his talk about the complications of myeloma. So just talk a little bit about pain and bone disease. Bone disease can include, of course, pain, pathological fractures, high calcium and cord compression. Up to 2/3 of our myeloma patients present with pain upon diagnosis. Pain can be caused by destructive bone disease, such as fractures, and sometimes plasmacytomas, which are soft tissues of myeloma disease, can compress the nerve roots or the spinal cord, causing severe back pain, along with weakness, numbness of the lower legs, or even affecting the bladder and bowel functions. Some of our patients may already have pre-existing comorbidities such as osteoarthritis and carpal tunnel or nerve damage due to diabetes and severe B12 deficiency. These may also be present upon diagnosis and should be managed accordingly. And finally, a sizable proportion of patients treated with especially thalidomide, bortezomib, can also develop what we call chemotherapy-induced peripheral neuropathy. And switching or dose adjustment of these treatments may be required if they're severe, including painful neuropathy. So managing pain requires a multimodal, mechanism-based approach, including pharmacological therapies such as pain relief and bisphosphonates, alongside our non-drug methods such as surgical interventions, radiotherapy, and where appropriate, psychological techniques. And really, regarding pain relief, pain management is based on an analgesic ladder that includes simple painkillers such as paracetamol, weak opiates such as tramadol, and strong opiates such as morphine and opiate patches such as fentanyl. We should try and limit, or if possible, avoid non-steroidal anti-inflammatory drugs such as ibuprofen or diclofenac if possible, especially in those with kidney impairment. And if it needs to be used, try and limit the duration to less than 5 days. Of course, sudden onset of moderate or severe pain, such as after a fracture, the injectable form of painkillers are usually needed because of the severity. But people may find that neuropathic pain, that agents such as gabapentin or pregabalin are more useful. And we should not forget to consult our pain team or palliative care team if the pain relief is inadequate and we couldn't get on top of it. Radiotherapy is quite effective for pain relief, especially for severe localized pain due to bone infiltration or nerve root compression, and may also palliate soft tissue disease as well. And there's vertebroplasty and kyphoplasty that can be performed for uncontrolled and persistent pain arising from vertebral or wedge collapse of the spine. Percutaneous vertebroplasty is done by interventional radiologists in some hospitals and by the orthopedic surgeons in some other. Now, this is a procedure where a special cement is injected into the fractured vertebra with the goal of relieving spinal pain and restoring mobility. Balloon kyphoplasty, on the other hand, is normally performed by our orthopedic surgeons, and it also involves injecting this special cement into the vertebra, but with the additional step of creating space for the treatment with a balloon device. It can also restore the damaged vertebra's height and relieve pain. Now, if the severe pain is caused by such as a bone fracture or causing immobilization, it may respond to a local nerve blockade or local anesthetic. But surgery is almost always required for very high-risk fracture of the long bones, spinal cord compression, fractures, or unstable spine. Coming to bisphosphonates. Bisphosphonates reduce bone destruction, reduces the release of high levels of calcium, which can lead to kidney failure. It reduces bone pain, preserves the bone density, and help keep the bone strong. It was also shown to prolong progression-free survival and overall survival. Patients should be treated for vitamin D deficiency and have a dental assessment prior to commencing bisphosphonates. And there are several types we use, the most common one being zoledronic acid, or Zometa, we call it. Other people may use palmidronate and denosumab for those with more severe renal impairment. And in patients with no active bone disease and who have very good myeloma control, stopping bisphosphonates can be considered after 2 years and restarting when the disease relapses. But some clinicians also prefer to give it less frequently, for example, 3 monthly instead of completely stopping it. Now, no treatment's ever free of side effects. It's important that we can effectively counteract some of the experienced side effects of myeloma treatment, not only to improve the quality of life, but to make these treatments more tolerable. We will often offer anti-sickness if the patients are feeling nauseated. A stomach protection such as omeprazole is usually offered to patients on steroids. Constipation is quite common with thalidomide and strong opioid painkillers and needs to be managed accordingly. Anti-diarrheal medicine, example loperamide, may be required for patients on long-term IMiDs such as lenalidomide and ixazomib. Risk of thrombosis of blood clots is from the myeloma disease itself, from immobility, as well as from certain treatments such as the IMiD category, thalidomide, lenalidomide, or pomalidomide especially. We often offer them either antiplatelet agents such as aspirin or blood thinners such as Clexane to prevent these blood clots. Neuropathy is more associated with certain types of treatments such as bortezomib and thalidomide, but these symptoms are usually cumulative and needs to be closely monitored, with the possibility of titrating the dose or switching to other agents if severe. Then there is osteonecrosis of the jaw, or ONJ for short, where exposed necrotic bone, jawbone, doesn't really heal after, let's say, a couple of months in a patient who's receiving or recently exposed to bisphosphonates. The most common precipitating event is because of dental extraction. And that's why teeth extraction and all the work should be done before starting bisphosphonates. And one should try and avoid, if possible, invasive dental procedures as much as possible. Now, there are some late effects or health issues that can occur with months or even years after diagnosis. And these may include organ dysfunction as a result of myeloma itself, or the treatment for myeloma, for example, heart and kidney impairment, endocrine problems such as hypothyroidism or low potassium hypokalemia. Annual screening for complications is recommended, and referral to specialists may be required. Engaging with primary care to optimize patients' pre-existing comorbidities would also be essential to further reduce end organ damage and impairment and their complications. The treatment of myeloma patients is never complete without complementary therapy integrated with conventional medical care to optimize quality of life at all stages of their disease. We should always try and focus on nutrition, exercise programs, keeping our patients active, engaging with the physios to optimize our patients' physical well-being, relaxation techniques such as meditation, aromatherapy, emotional or spiritual health support from either counseling, patient support groups, or religious groups are really essential for building up our patients' psychological resilience. They can also help patients alleviate stress and anxiety in coping with the symptoms and the disease better, and can improve sleep patterns as well. Support for practical concerns such as financial assistance, transportation to and from treatment, and social care services are equally important. Palliative care service incorporates many different approaches to provide pain and symptom relief and improve the quality of life in helping our patients live as fully as possible. They also really understand our patients' preferences and care options, helping them make informed choices about their treatment and the rest of their palliative care journey. So in summary, supportive care in myeloma should be throughout the entire journey of myeloma, from diagnosis through the multiple relapses until the end of life. And the holistic needs assessment needs to be done at multiple time points. And a multidisciplinary team needs to be there to address the ever-changing needs of patients throughout their journey. With this, I'd like to thank you for your attention.
Thank you, Dr. Alison. Please type in your questions for Dr. Alison in the Q&A box, and Dr. Alison will answer your questions. Next, let us welcome Dr. Chandramouli Nagarajan, who is a senior consultant from the Department of Haematology at Singapore General Hospital. Dr. Chandramouli will be talking about common complications of myeloma. Dr. Chandramouli, please.
Thank you, Simi. Thank you for your time logging in and spending a couple of valuable hours with us with a keenness to learn more about your disease or your loved one's disease. Is my voice clear?
Yes, Dr. Chandra.
Thank you. I realize that many of the information that I'm going to provide you have probably been covered in the prior talk. So I'll try and keep it as simple and short and sweet as possible in as much of layperson's terms as you have put on the feedback, so that the key message that I want to drive home is for you as patients and carers to be able to identify the potential complications that might be developing for you or your loved ones, such that you can bring it up to the doctors, when you go for consults. Ask those relevant questions to them. That's the main aim of this, to try and identify things early, and to what can, as a patient or a carer, you can do to try and prevent some of these complications. There are many complications that a myeloma patient can potentially suffer during the course of the illness. However, I'll try and keep it in the interest of time to the most common ones. And perhaps if somebody has more specific questions, I'll be leaving plenty of time to take those questions during the Q&A session, or you can type them in your Q&A box as well. These are the three broad topics that we will be covering today. One, the disease-related complications. How can we prevent and manage each one of them? And I'll also show a couple of interesting videos, which are actually from they are from the public available websites, for example, like YouTube. These are constructed by very good animation companies, by agencies like the Multiple Myeloma UK, where I used to work before. Just by way of introduction, for you as patients and carers to remember, we used to learn the short forms called CRAB. Going back to my medical student years, during the second years, this is something that we learned. And you can use that same short form to remember what are the potential complications for myeloma. We call it CRAB, standing for calcium, high calcium levels, renal impairment or kidney problems, anemia, which is low red blood count. Red blood cells are the ones that carry oxygen around your tissues, and bony lesions, which are areas of bone that is affected by the myeloma, which in turn can give you pain, usually in the back, and we'll go on to explain more about that. But sometimes the bony areas can be so much afflicted by myeloma that it can lead on to the bone to break, causing fractures. So that is what CRAB stands for. And as I mentioned, there are many other complications, which maybe in the interest of time, we can leave them out for now, but maybe in a future forum, or if somebody wants to take it up as questions, we can take them up as well. So I always try to give some background of the scientific reasons of why things are happening, so that some of that probably can stick into your mind and can And I also have many patients who ask this specific question, why does this happen? So again, I'll try and keep it as simple as possible. So a bone is in a constant state of flux throughout our life. So there is bone formation and bone destruction going on a daily basis. The cells that kind of destroy the bone are called osteoclasts, and the cells that form new bone are called osteoblasts. So normally it's like yin and yang. There is always balance between the osteoclasts that destroy the bone and the osteoblasts that form new bone. What happens in myeloma is it clearly sways the balance away from the osteoblasts, more in favor of the osteoclasts. This results in more and more bone getting destroyed, and with time, the bones become very weak. And also, the myeloma cells have a lot of potential to secrete chemicals within the milieu of where they reside. So, as we all know, myeloma, the cancer cells in myeloma called plasma cells, which are the myeloma cells, they secrete these chemicals within the bone marrow, which is where they reside. So this seeps out into the surrounding stronger part of the bone called the cortical bone, and it leaches the calcium from it. This results in more and more bone weakening with time. And as the myeloma cells expand and outgrow the normal cells, a large part of the bone can completely be destroyed, leading on to all the complications in the bone, like weakening, fractures, high calcium, etc. So from a patient's perspective, how does this bone disease present? How do you feel this? Well, the most common problem that we as doctors and US patients feel or see, respectively, is backache. Low backache is probably one of the most common symptoms of myeloma, whether it is at diagnosis or even at the time of relapse. Focal bone pains, for example, ache specifically in the collarbone or specifically over your rib cage, can be another common manifestations of a small area of myeloma there that is being, developing. Especially this happens either at diagnosis or at the point of relapse when there is a local relapse of myeloma, like a tumor that forms in the rib cage, for example. One of the other common problems that we also see, especially as the patients get older, and we see, many of the older patients these days, because they live a very long time, even after the diagnosis of myeloma, is fractures. So fractures, we usually associate with people having a lot of significant debilitating injuries and stuff, whereas in myeloma, the main difference is you can have fractures even with doing virtually minimal or trivial injury. I even once had a patient who swatted a fly and broke her arm doing that. So you can see the degree of weakening that a myeloma patient can have in the bone if you have to fracture your bone by just trying to swat a fly. Now, it is also possible that some of these areas that are destroyed by myeloma can be entirely silent. And how do we pick that up? Only by doing specific imaging, like, for example, an X-ray, or more and more times these days, we are either doing a PET CT scan when we diagnose myeloma, or when we have a specific suspicion of something going wrong, or even an MRI scan. So these things can pick up an area of myeloma that is affecting the bone and causing it weakness, whereas the patient can be entirely asymptomatic and have no problems at all. So this is try and attempt to give you some idea of what can be seen on X-rays. So for example, this is on the left, a skull bone, X-ray of a head. And you can see perhaps an area that is very dark on the top, as well as multiple other smaller areas amongst the area of whiteness. So wherever you see white, it is normal, healthy, strong bone. Whereas the dark areas are perhaps we can call them as holes in the bones. They are not really holes in the bones. They're just areas that are weakened by the myeloma that we can see as holes in the bones. The one on the right is a right arm of a patient, which clearly shows both the top end and the bottom end of the arm bone being weakened by myeloma that is in a quite large place, which is clearly abnormal. Now, this is an image of a PET CT scan of a patient that shows, even for a lay person, you should be able to see there's a big blob of red tumor that you see, this is from a hip bone of a patient that shows a big blob of red. That is clearly a tumor that is coming out of the bone from the hip. That is again an abnormality, clearly, that is troubling the patient with pain and things like that. So now I'll start showing this video. Hopefully, you should be able to hear the audio. And if you miss any parts of it, you can go to YouTube and view the video. If you just type Myeloma UK, you should be able to see the video.
Bone is a living tissue, and throughout life it undergoes a continuous cycle of being broken down and replaced with new bone. This process, known as bone remodeling, is important for keeping our bones strong and healthy. Bone remodeling depends on two types of cells, called osteoclasts, which break down bone, and osteoblasts, which form new bone. The activity of the osteoclasts and osteoblasts is controlled by chemical signals they and other bone marrow cells, such as stromal cells, release. Normally, the chemical signals are balanced so that their activity is the same, meaning that the rate of bone breakdown and bone formation is the same and bone mass remains constant. In myeloma, the myeloma cells produce their own chemical signals, disrupting the balance of signals between the osteoclasts, osteoblasts, and stromal cells. This results in an increase in the activity of the osteoclasts and a decrease in the activity of the osteoblasts, so that bone is broken down faster than it's being made. The bone therefore becomes thinner and much weaker. If you have myeloma bone disease, you will probably have some degree of bone pain. You may also have one or more of the following: hypocalcemia, or high calcium levels in your blood as it's released from the bone, lytic lesions or areas of bone thinning, which often appear as holes on an X-ray, bone fractures, and vertebral compression fractures, when the bones of the spine become so weakened they collapse upon themselves. Treatment for myeloma bone disease involves treatment of the myeloma itself, together with other treatments such as bisphosphonates, painkillers, and radiotherapy.
Okay, so we'll move on to what can be done to perhaps prevent, and how do we treat the bone issues that a myeloma patient has. So as you will see, for most of the complications that are related to myeloma, the treatment and effective treatment of myeloma to make it go into a good remission is perhaps the most important part. It might sound obvious, but it is important to effectively treat myeloma so that the complications are kept to a minimum. Those of you who have, my patients who come to clinic, we always discuss about this physical activity thing, and that's very, very important. I can't overemphasize that. Now, for a patient who is perhaps a bit more debilitated with a lot of backache, with the movement is restricted, it might sound a bit counterproductive, but there is enough and more evidence to show that within the limits of each patient's physical activity that is possible, and it is important and not to again overemphasize. We have to avoid injuries, no doubt about that, but within the limit of what the patient's physical activity is, and this is perhaps where help from our physiotherapists can be of crucial importance. As long as you can keep good amounts of physical activity with careful avoidance of injury, it has been shown that it goes a long way in preventing many of the bone loss related issues in myeloma. Now, many of us in this part of the world, we do know that as Asians, we all have a lot of vitamin D deficiency amongst our population. And that's true of myeloma patients as well. So we always do check our vitamin D levels, and where the deficiency is significant, we do advise vitamin D replacement. That also helps in rebuilding the bone and making it stronger. In select few patients, in addition to vitamin D, we also do give calcium replacement, which is also important because calcium is taken away from the bone early on in the course of myeloma, and it's important to replace them for patients. Now, once patients have already suffered a degree of bone damage, what can be done? So if patients have a lot of backache or rib pain and things like that, we do offer an approach with increasing painkillers as required. By and large, we keep them for the shortest possible time, and there are many different types of painkillers, and we don't need to go into the details of it, and this is something that you need to discuss with your doctor. But more recently, over the last 10-15 years, they have come up with new innovative ways of replacing or rebuilding a damaged bone. And the image here is probably going to give you a better idea than what I'm going to say. If really a backbone has collapsed, there are two things that can be done. One, they can put a needle into that backbone because the vertebra has collapsed upon itself like a sponge. They put a needle in, expand it with a balloon a little bit, and then fill them in with the cement. When we just do the balloon part, it's called kyphoplasty. And when we also inject a cement, that is, the cement that they use here is not the cement that you use for building materials, but it's a different grade that kind of mimics the bone architecture and allows the bone to expand. And what that helps with is the nerves that are coming out of the spine are going to be compressed by this compressed sponge, the vertebral backbone. And when this is corrected, the pain gets better. Now, if that doesn't help, and in select patients, we may not be able to proceed with that particular procedure, then we can use radiation or X-rays into that particular area of bone, and that can again help with the control of pain itself. The other thing that we often do is the monthly injections, at least for the early diagnosed patients, of what we call as a bone protection agent called Zometa. Now, this helps by directly inhibiting those osteoclast bone destroying cells that we talked about earlier. And in doing that, it helps to shift the balance or rebalance it more towards the bone building osteoblast. And in doing that, the purpose of doing that is to minimize the damage that has already been caused. And it, to a large extent, it has been shown that it minimizes the number of fractures that a patient with myeloma potentially can suffer. These agents, the Zometa in particular, they can stay in our bodies for a long time. So it is not necessary to continue the Zometa indefinitely. And we are always careful about that because they have other problems, for example, causing kidney issues, which is the other problem that I'm going to talk about next. In select patients with very significant kidney failure, we may not be able to give the Zometa, and we might have to use other agents, for example, denosumab or palmitonate that Dr. Alison Soh mentioned. So with that, I will move on to the next complication, and I want to give you a bit of an idea again about why we do get infections so commonly in myeloma patients. Again, keeping it to a very layperson term, if we can divide it, our immune system is divided into what we call as innate immunity, or you can imagine this as something that we are born with, and adaptive immunity, which is immune system that we get as we grow as children into adults and beyond. This is the part of immune system that matures with us by learning to respond to the different germs and bugs that we get exposed to from the environment. Innate immunity is more brute force, if you like. It sees damage or danger coming in to our bodies. It directly affects them on the spot. Whereas adaptive immunity is a bit like more intelligence in our security parlance. So you can imagine them as cells that carefully identify the germs and bugs that comes into our body and learns to produce things called antibodies, which are specific for that particular germ or bugs that has stimulated its development, such that they can go and target them specifically. Now, there are innumerable defects in both the innate immunity as well as adaptive immunity in patients with myeloma. And that is what leads on to the development of infections in our group of patients. So just one slide on what are the problems. So as I mentioned, both the naturally born immunity as well as the adaptive immunity gets affected. And as you know, the myeloma cells or the plasma cells are the main ones which are the ones that are producing the antibodies against the germs. So when that cell in our body has turned cancerous, our immune system does become quite weak. Yes, it is producing a lot of those antibodies, which is what we call as MBAN in the end, that is produced by the cancer cells, but they are essentially functionless and hence not useful to counter infections. Now, what do we see as myeloma patients with infections? We see them having infections, the risk at least is highest in the first year after their diagnosis, and periodically after that, at the time of their relapses. Every time they do relapse, the immunity is that much more weaker, and they are at higher risk of getting those infections. And there are additional factors within myeloma that also increases the risk of infections. For example, a patient who has got a spine collapse means that they can't take a deep breath in because it hurts them, or it limits the amount of space within their lung compartment within the chest, such that the lower part of the lungs are prone to develop things like pneumonia. Now, in addition to myeloma, we also have other patient-related factors. For example, an older patient might perhaps have additional problems like kidney. Either it is related to myeloma or it may not be, or heart problems that may or may not be related to myeloma. Or lung problems, for example, those can add on to the risk of infections in a myeloma patients. Finally, other things like diabetes, especially when the blood sugars are not very well controlled, can also add on to the risk of infections. And as myeloma doctors, we do realize that there are lots of contributory things that we throw in as a part of treatment. For example, steroids. That's a big issue that we always pay very keen attention to. And I'll go on to explain what can be done in those kind of situations. But these drugs that we use to treat myeloma, unfortunately, to some degrees also contribute to the occurrence of infections in myeloma patients. One slide on what are the infection types that a myeloma patients can get. So bacteria are a type of germs that we all are exposed to. And to be honest, our body, every inch of our body has many of these good as well as bad bacteria inside us. And some of them can take hold and cause infections in a myeloma patient when their infections, when their immunity is a bit low and they are in a vulnerable state. We do see bacterial infections, especially early on in the course of myeloma. But as a myeloma patient gets more and more treatment and more other organs are affected, the risk of getting other types of infections, not just bacterial, also increases with the degree of suppression of your immune system. But the most common bacterial infections, by and large, we see is either pneumonia, which is a lung infection, or other non-lung upper respiratory tract infections like common colds, flu-type infections are probably the most common things that we see as patients, and we see in our patients, and you as patients would have experienced that as well. Other common infections are urinary tract infections that you experience probably as pain when you pass urine or discomfort, and gastrointestinal tract infections like diarrhea and dysentery or other things that we see. One of the most common viral infections that we see in our patients is shingles, and many of you might have experienced it. It can often happen again early on in the course of the illness, or when particularly the immune system is poor. I see this sometimes in patients, despite the fact that they are on medicines to prevent that during the course of their relapses in particular. Now, another common viral infection that we do see often is in our population. We do know in Singapore, about 15% of our general public have been exposed to hepatitis B in the past, and a vast majority of them still harbor the hepatitis B inside them. And normally it doesn't affect their at a very low level, but in patients with myeloma, when we especially do things to them like transplant, they have a potential for the hepatitis B to flare up and cause serious liver damage. And that is one of the reasons why we offer preventive treatments for this type of chronic dormant infections in their body. Increasingly, as we take on an approach to treat myeloma more aggressively, to let them go into a stage of quiescence for a very, very long time. So, for example, when we use antibody-based treatments like daratumumab with 2 or 3 other myeloma drugs like Velcade or lenalidomide, or both of them together, we do see more of uncommon or less common infections like fungal infections, for example, or a specific type of virus, which happens usually in transplant patients. We also see them happening outside of these time periods because of the amount of treatment that patients are having. So drugs cause disease. That is one of the key things that we learn as doctors when we go through our medical school, and it is certainly true in myeloma patients as well. You may all realize that one way or another, one time or another, you've all gone through this Velcade injections. They do have a propensity to predispose patients to shingles or other type of viral infections. So we always give acyclovir tablets to you when you're on this treatment. Now, the second group of drugs called IMiDs or lenalidomide or Revlimid as we call it, is one of the group of drugs that can cause low white blood counts. And these are the medicines that are often associated with bacterial infections like pneumonia or urinary tract infection, for example. And more recently, with the use of antibody drugs like daratumumab, we do see a combination of both of above because probably the most common or most likely reason for this is daratumumab is more often than not used, not alone, but in combination with other medications. Finally, transplantation being the a very high intensity treatment is probably a most vulnerable period for myeloma patients to develop infection. So quickly going through what can be done to prevent these infections and how do we treat them. So what can you do as patients in general? Good nutrition, keep yourself healthy, hygiene, personal as well as environmental hygiene where you often hang out either at your home or office. Those things, commonsensical precautions can go a long way. From a treatment point of view, what I tend to do, and I'm sure this is the same pretty much across the different institutes in Singapore, steroids are a necessary evil. They do have a very potent action against myeloma cells. So we do give them in fairly large doses when we start treatment for a patient with myeloma. However, rapidly, as soon as their myeloma is very well controlled, it is absolutely crucial to minimize the steroid dose to the most minimum dose that is required. And this is best advised by your own doctor who knows your situation very well. But that can go a long way in minimizing the long-term complications, especially with infections. And as I mentioned to you in different slides, commonly used antiviral medicines like acyclovir, which is a pink tablet in most of your preventive medication group. Anti-pneumonia medicines that you take Monday, Wednesdays, and Fridays. That's the Bactrim or the Cetrin. And in select patients, we might also elect to give you antibacterial antibiotics. And it has been shown in large trials that when we give antibiotics for a finite period, soon after diagnosis or at the time of relapse, it does bring down the number of complications with infections that patients suffer while we work on treating their myeloma into a quiescent stage. And as I mentioned, hepatitis B preventive treatment or prophylaxis, as we call it, is also very valuable in select group of patients that are going through treatment. Now, one thing that Dr. Allison also alluded to is something called immunoglobulin. So these are blood products that are collected from other donors, which is the good part of the antibodies, if you like, that our body produces. So obviously, as a myeloma patient, with the myeloma cells taking over these antibody productions, which I mentioned are useless, we use this good antibodies from blood donors to replace what a myeloma patient does not have in their body. Now, it doesn't have to be done for every patient. Indeed, it's a rare commodity, it's very expensive, and it does have its fair share of complications. So we use it in a very selected group of patients where we find that the patients, despite doing all the other things, are getting repeated infections. That's the group of patients that we use this for. And finally, a note on vaccination, which I have no doubt that Viju will cover in more detail. Vaccinations are absolutely crucial. It's a very valuable tool that we can use to prevent many of the infections that a myeloma patient can suffer. Generally, vaccines are divided into live attenuated vaccines and killed vaccines. Killed vaccines are where the bugs or germs that we are trying to immunize or vaccinate a patient against are killed, and hence there is no scope for that bug or germ after it has been inoculated into the patient to start producing an infection. What it does often is elicit the white cells to produce a response to the killed germ that has been injected. And in that process, if the patient encounters the same bug or germ in future, they will be able to respond to it in a effective manner such that the infection does not harm the patient too much. Some of the common vaccines that we use for our patients is pneumococcal vaccine, which is a type of pretty bad type of pneumonia causing organism. And there are many additional ones, for example, diphtheria, tetanus, and so on, that we often give, especially for post-transplant patients. Obviously, the one vaccine that is in everybody's mind in the current environment is the COVID-19, and I'm sure Prof. Chng will cover it in detail. But essentially, it is also an important vaccine that from here on that every myeloma patient should have. We can discuss more about that after we do session. Okay, swiftly moving on to the final complication that I'll be talking about is myeloma kidney disease. So why does myeloma patient have a propensity to have kidney damage? One, because the proteins that are being churned out by the cancer cells in myeloma patients goes and literally clogs up the kidneys, and that way affects the filtration function of the kidneys. Second, if you are unfortunately not drinking enough fluids, it causes dehydration. It makes our body that much more difficult to remove this M-band protein that is being produced by the myeloma cells, and hence that contributes. One of the other complications that we learned about early on is the high calcium level, which unfortunately makes the person excrete more water. And if you again don't drink enough to compensate the extra amount of water that you're excreting as urine, it predisposes to dehydration and causes the kidney failure as well. And finally, as I mentioned, drug-caused disease, and some of the drugs that we use, especially painkillers like ibuprofen, Nurofen, Voltaren, and things like that, can precipitate kidney failure in a myeloma patient. And that's something that we cannot underestimate. Now, a quick video again on the myeloma kidney disease.
Myeloma kidney disease is a relatively common complication of myeloma. 2 out of every 10 patients at diagnosis have kidney damage because of their myeloma. And a further 4 out of 10 patients may develop kidney problems later on. We each have 2 kidneys that are located just below the rib cage on either side of the spine. Their main job is to remove waste products from the blood. This is done by the many thousands of filtering systems called nephrons. Damage to the nephrons prevents them from removing waste products efficiently and can cause serious illness. There are many causes of myeloma kidney disease. The most common is the damage caused by too many free light chains. Free light chains are the unattached portions of the abnormal antibody or paraprotein that are produced by the myeloma cells. Normally, they are filtered through the nephron and removed when taken up by the cells that line the tubules. However, sometimes the amount of free light chains can overcome the ability of the tubules to remove them, and instead they cause blockages further along the nephron. These blockages stop the nephrons from working properly and can cause severe kidney damage. Other possible causes of myeloma kidney disease include high calcium levels in the blood because of myeloma bone disease, dehydration, urinary tract infection, and certain drugs such as bisphosphonates, non-steroidal anti-inflammatory painkillers, antibiotics, and some anti-myeloma treatments.
Okay, so hopefully that also re-emphasized some of the points that I mentioned. So finally, a word on what can be done to prevent and how do we treat kidney disease in myeloma patients. So crucially, what as patients can do, make sure that you drink plenty. Again, this is not this reasonable blanket recommendation, but there might be specific differences amongst patients. For example, if you have coexistent heart disease, for example, that might change what and how much of fluid that you can or can't drink. So it's important to discuss with your doctor how much you need to drink on a regular basis. Steroids, as well as the Velcade type medicines, are absolutely crucial in quickly treating the kidney problem that a myeloma patient can suffer. Because once we allow the kidney failure to establish, it becomes very, very difficult to shake that off after that. So it's important to quickly jump onto the treatment and get the kidneys back to a normal state or as close to a normal state as possible. Now, you might all have heard about this medicine, Allopurinol, which many patients, as you have gout, might take on a regular basis, but Often in myeloma patients, they also start these medicines at the time of diagnosis or relapse, because there's a harmful chemical called uric acid that these cancer cells produce or discharge into the blood when these cells get destroyed. And allopurinol can prevent this uric acid from harming the kidneys. And as mentioned many times, both by Dr. Allison and myself early on in the talk, avoid all non-essential painkillers and medicines, because that can go a long way in preventing or precipitating a kidney disease in a myeloma patient. Also, do remember that your myeloma may be something that you discuss often with us as myeloma doctors, but it's important if you have other medical problems to mention to those doctors and pharmacists and other nurses that you come across, because they might want to start you on a specific treatment for the problem that they are dealing with, but inadvertently, they might cause a problem in the kidneys, for example, which if they had known about this myeloma problem, it might make them think twice before they administer. And there might always be alternatives that they can use. So finally, in conclusion, we do understand that multiple organ systems can be involved or in some way, shape or form contribute to a patient's health or lack of it in a myeloma patient. And it requires often, as you can see, the extent of the problem that a myeloma patient can have. We need a systematic and multidisciplinary approach. And often you might find us referring you to, for one of our colleagues, for example, to orthopedic department or to the kidney department. And we do all have an approach where, I have specific kidney doctors or orthopedicians that know much more about myeloma, and hence they will be able to specifically address the problem that the myeloma has caused in the specific organs in their own discipline. So it's important to have that kind of group of physicians who understand this problem better. As I mentioned, in some of the issues that I've mentioned, problems are better prevented rather than trying to cure them after they have happened. So where possible, you can contribute as well by doing your part and always stay vigilant for any of these complications. It's important that you discuss any problems that you come up with. Don't brush them under the carpet. Discuss that with your respective doctors, and work together with them to how we can get this better for you. And as I mentioned, for many of these problems, we do realize that treating the myeloma to quiescence goes a long way in preventing and minimize these complications. So with that, I'll stop and be happy to take questions at the end of the session.
Thank you, Dr. Chandramouli. Dr. Chandramouli will be answering your questions with the rest of the speakers at the end of the session. Let us now invite our third speaker, Dr. Daryl Tan, who is a consultant hematologist at the Mount Elizabeth Novena Hospital. Dr. Daryl will be sharing more about treatment for transplant ineligible patients. Dr. Daryl, please.
Daryl, you're muted.
Oh, okay. All right, can you hear me? Right. Okay, sorry about that. So my task is to talk about treatment for transplant ineligible patients. Earlier on, there's a request from one of the participants to answer what multiple myeloma is. This year, we have unprecedented number of patients participating. So we might have overlooked that some of you might not be myeloma patients. You may not be myeloma caregivers. So I've just conjured one slide to explain what myeloma is. Essentially, it is cancer of the plasma cell, which is a kind of white blood cells in the bone marrow. Normally, the plasma cells secrete antibodies to help us fight against infections. So when a patient gets myeloma, these antibodies that produce are called cancer proteins or M proteins. They can choke up your kidneys and cause kidney damage, as alluded to by Dr. Chandramouli. And also, these myeloma cells in the bone marrow can start to result in the bones being eaten up. That's why you get bone issues. And by having these cells proliferating in the bone marrow, they crowd out the normal blood-forming cells. So patients get low red blood cells, low platelets. As a result, they get bruising, bleeding easily. Now, so my task is to talk about treatment for transplant ineligible patients. And for the benefit of new participants joining us this year, let me explain what autologous stem cell transplant is and who is not eligible for autologous stem cell transplant. So this slide charts the evolution of treatment for multiple myeloma. I would say that up until the 1980s, we couldn't define or change the natural history of multiple myeloma. By and large, patients were still surviving on the average 2 to 3 years, and many of them ended up with very bad bone disease, like Sarah Newsbury, the very first case of multiple myeloma described in 1844. Well, the World War came and chemotherapy was accidentally discovered. A combination of these chemotherapy drugs could lead to effective control of symptoms, but then again, they couldn't prolong survival of patients with multiple myeloma. So autologous stem cell transplant was developed in the 80s. Essentially, it is allowing the body to receive a very high working dose of a drug called melphalan. And prior to this being given to the body, your stem cells are collected, frozen down. Melphalan is given to the patient. Essentially, melphalan is in such a high dose that it reboots your bone marrow, kills off most of the myeloma cells in the bone marrow. But without doing anything after that, your bone marrow could suffer and could degenerate. So that's why the autologous stem cells will be reinfused to allow the bone marrow to recover faster. So in Singapore, by and large, we can transplant patients up to 70 years of age. So why is this age bias and discrimination? Melphalan kills rapidly dividing myeloma cancer cells, but in our body, there are also other dividing cells as well, cells lining the gut, cells in your hair follicles, and cells in the bone marrow. As a result, you get very notorious side effects like diarrhea, nausea, hair loss, vomiting, infections, and second cancers. All these are complications that the previous speakers have alluded to. As a result, older patients will not be able to tolerate the toxic effects of high-dose melphalan. But then again, not all elderly patients are equal. You can have the hunk to the left. He could be more than 70 years of age, but he can still go for autologous stem cell transplants if the doctors deem that he's still of a good physical shape. By and large, most patients who are older, unfit, and frail, we will not try to do autologous stem cell transplant, but rather most of the time we would taper treatment for these patients to reduce the side effects. But the problem with tapering treatment is that you could compromise the efficacy of the treatment by having dampened doses of drugs. Just to reduce toxicities, the control of myeloma could be compromised. So it was always thought that without autologous stem cell transplant, we may not be able to achieve a very good control of the disease. But in this day and age now, we can't be more wrong. I'll show you why in a bit. So in a nutshell, this is the treatment schema for patients who are transplant eligible and transplant ineligible. What sets them apart essentially is this phase called consolidation of the autologous transplant. So overall, traditionally, we see that with stem cell transplant, the time to the first relapse is about 4 to 5 years after frontline treatment. Whereas for patients who are not transplanted, the time to first relapse is about 2 to 3 years. But I must reinforce that these data could slowly get obsolete because this is a moving goalpost and we are improving on these data every year. Now, the introduction of the first generation of novel drugs like bortezomib, thalidomide, and lenalidomide that you're quite well familiar with has sort of like converted myeloma from a terminal cancer to a chronic disease. So with the introduction of next generation novel drugs, many of us and many of patients are asking, in this year, 2021, do we still need to do autologous stem cell transplant, which is like a savage procedure for some of the patients who have gone through. Well, whether or not to drop or to abandon autologous transplant is really not based on a hunch with these new drugs. But essentially, before we can put forth a recommendation, we carefully do survival analysis. Essentially, this is like analyzing a cohort of patients given a certain treatment over time. And every time a patient relapses, the curve starts to drop. And as you can see, for treatment A and treatment B, they're essentially the same, but treatment C is superior because the curve is less steep And with these kind of analysis, we can easily estimate the median time to relapse. For instance, for treatment C, the median time to relapse is 36 months. It doesn't mean that majority of patients will relapse at the 36th month. It just means that out of 100 patients, the 50th patient could relapse at 36 months. But there are 49 other patients who could relapse later on. So with the experience of autologous transplant over the years, we have always noticed that at the tail end, perhaps about 10% of patients do not relapse at all. Of course, this is just a small minority, and as a result, we cannot say that we can cure multiple myeloma. But our intention is really to prolong the time to the first relapse as far as we can. This is a recent major study that randomized French and American patients between upfront transplant versus no transplant. From this study is indeed showing again that in the current era, with the use of autologous transplant, the time to first relapse is still in favor. If you go with an autologous stem cell transplant, you could gain in excess of about 1 to 1.5 years compared to someone who is not transplanted. So as a result, in the year 2021, if a patient is young and fit, we would largely still recommend autologous stem cell transplant for patients with newly diagnosed myeloma. However, what got us really excited over the past few years is actually our ability to measure minimal residual disease. Now, commonly, when you see your doctors for follow-up for myeloma treatment, we do bone marrow biopsy, we measure the M protein or the light chains from your blood. But there is a threshold to the sensitivity of these tests. Now, with newer technologies called next generation flow cytometry or next generation sequencing, we can now actually measure minute amount of diseases that cannot be measured previously. Can you imagine if you don't even detect these minute amount of diseases? Perhaps we're secretly optimistic that if we do not measure, we cannot measure MRD, and this is sustained, we could potentially be looking at the prerequisite to cure. So the aim of many myeloma physicians is really to help attain MRD negativity amongst our patients with multiple myeloma. So coming back to the same study, why transplant is still advantageous is because more patients who were transplanted were able to attain MRD negativity. But then again, we realized that with modern treatment, actually a small minority of patients who were not transplanted were able to attain MRD negativity as well. So the quest for us actually is to put more patients onto this curve, allow them to be MRD negative even without the use of stem cell transplant, as we know that once you can eradicate the last bit of your disease, your myeloma control will really go a long way. Well, one way that can get us there faster, that could augment our upfront treatment to allow us to attain MRD negativity, is the introduction of immunotherapy. Essentially, it is the ability to harness our immune system to fight multiple myeloma. There are several modalities, including antibody called daratumumab, eloxuzumab, and CAR-T therapy. So this year, HSA has approved the upfront use of daratumumab, which for the past 5 years was only allowed to be used in the relapse setting. So it has been granted approval for use in the frontline setting. So now we are increasingly adding daratumumab to the frontline setting. So what this drug does is that it attaches to antigen or protein on the myeloma cell called CD38. Once it does so, it stimulates the immune system to take out the myeloma cell. It tags the myeloma cell for destruction by our immune system. Now, this charts the evolution of treatment for transplant ineligible patients over the years. I would say that we can really appreciate how far we've come, the advances in the treatment of multiple myeloma, by looking at how we are treating patients who are transplant ineligible, because we're not cheating this time around, because we're not doing high-dose melphalan with autologous stem cell transplant. So you can see that these alphabets stand for common drugs that many of you may be familiar with. In the early days, we used melphalan prednisolone. Then we added thalidomide that resulted in a lot of numbness of the fingers and feet. And then Velcade came along. We used the VMP quite frequently in the early 2000s. Then there was this regimen called Revlimid, dexamethasone. And of late, we began to add daratumumab to these backbones. The good thing about daratumumab is that because it's a monoclonal antibody, it's like a protein, so it doesn't really give rise to a lot of side effects that you would expect with conventional chemotherapy. So I could even give daratumumab to a patient who is 90 years of age, and he or she wouldn't come down with significant side effects. So over the years, we can see that the success rate of using these combination treatment increases over the years. With melphalan prednisolone, only about a third of patients may respond. Later, with bortezomib or Velcade, we see 70% of patients responding to treatment. And now by adding daratumumab to our backbone of bortezomib or lenalidomide, you can see that in excess of 90% patients will respond to frontline treatment. So what is also more important is that how long will the remission last? With the first treatment, how long can patients stay in remission? Well, in the earlier years, we were just seeing like remission for a year, then 2 years, 3 years. And now with the latest data on daratumumab plus Revlimid and dexamethasone, this is based on a major international study called the MAIA study. They reported that the median time to relapse is actually 60 months. This is unprecedented. So, hey, isn't this what we can expect with stem cell transplant, which I alluded to early on? Yes, indeed, right now, without autologous transplant, time to first remission can be as long as 5 years, which is something that is really, really promising. And in the earlier years, we dare not think about MRD negativity for someone who has never been transplanted. As we use new drugs upfront, we're beginning to realize that, hey, we are getting to see some patients without transplantation attaining MRD negativity. So with daratumumab-based combination, actually, about 30% of these patients can attain MRD negativity, which is fantastic without having the need to do an autologous stem cell transplantation. Now, in a nutshell, I've mentioned this is how treatment of myeloma is currently, but in the very near future, I would say that with very effective ways to treat myeloma upfront, we can do away with the rebooting system. Perhaps in the very near future, we may do without autologous stem cell transplant, and we could totally remove this discrimination of labeling a myeloma patient as being transplant eligible versus transplant non-eligible. Now, coming back, I've showed you the good news of how far we've come, but the bad news is that these drugs really cost a ton of money. Daratumumab, right now we've converted myeloma to like chronic disease. Chronic disease means that you have to be on the drug or else the treatment may not be effective. So by giving continuous daratumumab on a continuous basis, the costs can really be exorbitant. Well, the saving grace now, especially in many countries in Southeast Asia, is the introduction of generic drugs. Right now, generic lenalidomide, generic bortezomib are now being made available because the patents of these drugs are coming off. Hopefully this year, we could see the generic drugs come into the market. This could really defray the cost of a very effective upfront combination. Well, what is the lifetime cost of treating patients with multiple myeloma? This slide shows that actually with these new drugs, the survival of myeloma patients is really inching closer and closer to the survival of patients or healthy individuals. But of course, there is a price to pay. And this is based on US statistics. For 1 year of Dara, Revlimid, dexamethasone, the cost is really phenomenal, $290,000 a year. And of late, I'm sure you have noticed in the news, this is probably about 1.5 months ago, that the government is coming in trying to control costs of cancer drugs and stipulating what your MediShield and your integrated shield plan can pay for and what it cannot pay for. And of course, as cancer patients, you always want to have greater access to these drugs. What if you have used up the drugs in the list that the government approves? What happens next? Does that mean that you are coming to the end of the road? Can you still tap on to drugs that are not approved? So these are many issues that are faced by myeloma patients. Actually, right when this was published, some of my patients call me up and say that, hey, on this list that the government claims that they will allow MediShield to be tapped on, daratumumab is not on this list. As you can see, for other drugs like the Satinib, they're all in the MAF, which is Medication Assistance Fund. Once the drug enters MAF, it will make the drug way cheaper for the patient. Well, fret not, because this is still work in progress. This will only take off in September 2022. Hopefully, the government is still in negotiation with the pharmaceutical selling daratumumab. So this is not the final thing as yet, but certainly as physicians, we will also want to put a strong case across to HSA that some of these drugs are really essential and we want them to be on the list for use because they show really good benefits for myeloma patients. So overall, to put everything in perspective, what I've just mentioned is just the first treatment, trying to attain the first remission. But for a patient with multiple myeloma, there'll be second relapse, third relapse, fourth, and fifth. And the trend is that with every sequential relapse, the cost of drugs becomes more and more expensive. One of the ways to treat myeloma, which is approved by FDA this year, is the use of CAR T cell. I will not elaborate what CAR T cell is. It's a form of immunotherapy, but unfortunately, this is one of the most expensive treatments. Actually, CAR T has been approved for lymphoma in Singapore by HSA, and one dose of CAR T, if you get treated in SGH, unfortunately, is a stunning $500,000. And the integrated shield plan is only covering, most integrated shield plans is only covering half of this. So it is almost impossible for an average Singaporean to come out with $250,000 just to fund for CAR T cells. So there's, so what I have alluded to is that I just want to highlight the key to best survival outcomes in myeloma is really the continual access to effective novel drugs. And this slide sort of like pieces together how everything comes in. We are all in this together. These are the major stakeholders to determine how we can get early drug access and how we can reduce the cost of drugs for your lifelong journey with multiple myeloma. The healthcare authority is important, the pharmaceuticals or the industry, physicians and patients. So a healthcare authority is responsible in negotiating prices of and formulary control, allow importation for personal use when standard of care fails, and also to facilitate easy entry of generics. While we always plead with our pharmaceutical companies to lower the price of the drug, it would be good if they can be a little bit more transparent on research and development, and if they could lower the cost of drug development. Commonly, the price of a drug could be pegged to a GDP of a certain country, but to what extent is the GDP of Singapore translated to the ground person to the Singaporean? Well, it makes sense if there is universal healthcare, but by and large in Singapore, our healthcare is still self-paying. So there are a lot of issues that we need to discuss about how we can bring down the cost of drugs. For physicians, we try to improve treatment guidelines to optimize treatment outcomes with available resources. We educate patients. Of course, we always tell patients what is important to avoid Sabah snake oil for treatment of myeloma, and also to control fake news in the social media. That is of utmost importance nowadays. We also try to introduce clinical trials to avail a drug free of charge, and also to avail a drug earlier before it could be approved by the government. And as patients, sometimes you may not realize that patients can be a very formidable force. In addition to providing support, education during a regular group meeting like this forum, one very important task is actually to engage the other stakeholders, which this is advocacy, to lobby a certain idea to the healthcare authority or to the pharmaceutical. Unfortunately, this is still lacking in our Singapore context. This is something that we really want to build upon. Prof Chng has mentioned earlier in his opening address. So these are some very pertinent issues faced by myeloma patients in Singapore. At diagnosis, the myeloma patient will certainly need emotional support. I usually try to get another fellow myeloma treatment who has come off treatment to counsel a patient who is newly diagnosed, because myeloma is a rare disease. So it constitutes about less than 1% of all cancers. And so most myeloma patients will not be aware of another patient who died with myeloma. So emotional support is very important. It's pretty much like my my son going to primary 1, he's tagged on to a buddy in primary 4. So if we have a good system or support group that can take care of this buddy system to provide emotional support, this will be excellent. Cost of drugs, which I mentioned, is always a problem with multiple myeloma. If you want to refer to some US statistics, in the US, myeloma accounts for 1% of all cancers, but it accounts for 17% of drug expenditure or cancer drug sales. So this is really inflated 17 times for a single disease called multiple myeloma. What we need prompt approvals when standard of care fails, and I've mentioned that out-of-pocket cost for CAR-T, which is going to come to Singapore very soon, is going to be something that we need to address. And of course, availability of generics. How can we bring generics in promptly to defray the cost of these expensive combinations? I actually caught this movie from Netflix about a week ago. Has anyone watched this movie called Sweet Girl? Well, it depicts a girl whose mother was having terminal cancer and couldn't afford a proprietary drug. But when the generic came along, they were very happy, but something happened. The proprietary drug company blocked the release of the generic. And as a result, her mother died, and she grew up vowing to take vengeance. And essentially, she was plotting to kill the CEO of the proprietary drug company. Well, I'm not asking you to do this. So she had to do this because she was alone. But for you, we need to leverage on our strength in numbers. So a better model, which I always like to highlight, is the Dying to Survive model. This is a blockbuster movie in China about 3 years ago. A true depiction of a patient, Lu Yong, was a drug store owner. He came down with chronic myeloid leukemia. If you don't take a drug, you die. If you take a drug called Gleevec, you survive with normal life expectancy. So he imported Indian generics. In the process, he imported the drug for 1,000 other Chinese patients. But when the authority found out about this, he was actually convicted. But then again, his fellow patients that he rescued because of importation of generics from India rallied behind him. And as a result, the government dropped their case. He was acquitted. And because of this incidents, the central government actually cut some slack on importation of generics and the availability of generics. So you can see that when patients come together, you can indeed be a formidable force. So to close the loop, actually, this year we're trying to plan for a Singapore myeloma patient support group to really take off, to be on its own patient-driven, and with strength in numbers, you can actually engage the healthcare authority, engage the pharmaceuticals for various agendas, which I have highlighted earlier on, because this will really help you in your journey with multiple myeloma. Perhaps, anyone who's interested, please leave your email address so that we can get to you to work out how we can form the Singapore Patient Support Group. So to conclude, I just want to reiterate that myeloma patients are living longer and longer. Right now, the elderly is in control. There's a paradigm shift from hitting the cancer hard to hitting the cancer smart. So as a result, with these new drugs, the elderly patients may not necessarily come down with severe toxicities. And the key to improve survival outcomes is still the sustained access to novel therapeutics. And I can't stress more that engaging various stakeholders is really the key to finding solutions for affordability and to access the new drugs to control multiple myeloma. So with that, I thank you for your kind attention.
Thank you, Dr. Daryl. Now, let us welcome Professor Chng, Director of NCIS, to share with us about myeloma and COVID-19. Professor Chng, please.
Thank you very much, Sini. And I hope everyone is enjoying the webinar so far. We certainly have a lot of questions online and have been busy typing away. We'll keep some of the good ones or the interesting ones for the live Q&A session later. So do keep the questions coming. So, and also it's interesting, every one of us is dealing with COVID, and I'm going to talk a bit about COVID. I think one of the things I realized Daryl is doing rather a lot during COVID is watching all the Netflix stuff, right? We see Squid Game and Sweet Girl and others, but I'm glad that he can actually see the connection between some of the messages in these movies that are relevant to our patients and make it in a really light-hearted and relatable way, some of the key messages that we want to put across. And I think for the last couple of years, we have all been kind of struggling or trying to come to terms with this tiny, tiny piece of particle that is causing havoc around the world, right? The COVID-19 SARS-CoV-2 virus. And this is what it looks like. It is a circular organism that has a cell membrane that actually contain within it just a single strand of RNA. You know, it's a very simple viral particle, but this is causing so much problem. It is related to a bad coronavirus and also to the previous SARS virus that we have. That again was causing a lot of problem in the early 2000s. I want you to look at this picture a bit more carefully and notice these orange balloon pop-ups type of things that is all over this membrane, right? These are what we call the spike protein. And this is important because many of our vaccines that I'm going to talk about later are targeting this spike protein. But we also must take note that there are other proteins, other components of the membrane that we could potentially target, right? And also one day, if this spike protein mutates, then our vaccine may well be less effective, you know, and I'll talk a bit about mutation later on, which is, you know, the organism actually learn to evolve and change its structure and its proteins so that it looks a bit different from the original version, right? And in this way, they mask themselves from our immune system. So this is what we are dealing with, the COVID-19 virus. And why is it relevant to us, besides the fact that we have all these restrictions that is inconvenient to all of us, is because for cancer patients, we have a higher risk of getting the infection. And when we get the infection, it is more severe, right? And these are based on studies in the early days of the infection out of China. You know, we know that the risk is much higher in the cancer population, and not just that you have high risk of getting infection, but when you get it, it is more severe. So certainly something that is of concern to myeloma patients as well. But actually in the very early part of the pandemic, in fact, for the last 18 months or so during the pandemic, we were paying very close attention to whether myeloma patients in Singapore, in Asia, in the world, do get myeloma. And so these are a summary of the studies that have been published, predominantly in Europe and US. And we all know how prevalent the infection was in Europe and US. And indeed, they report many cases. You can see here, the detailed specific numbers and so on are not critical, but I draw your attention to the fact that, you know, there was a fair number of myeloma patients reported in different studies that has COVID-19. And also, indeed, the mortality rate, that means the people who died from COVID-19 that has myeloma, is quite high, right? I mean, we can see from these studies that it ranges between a quarter to half of the patients. Okay, but it's by no means always the case. So in this report from Germany, I think, small report, there was no mortality. So it's quite variable, really, and it all depends on, you know, what types of patients, what types of myeloma patients get COVID and the outcome. And some of the studies actually go deeper to identify some of the associations, right? So in myeloma patients with renal disease or with active disease, you know, the risk of dying is higher. But be mindful that these are studies from the Europe and US. And for the longest time, the only cases of myeloma patients with COVID-19 we know about are from China. And there were only very few, only about 5 patients reported in the literature. And when we talk to our colleagues from China, they all say that there's very, very few, right? Korea doesn't have any, Japan doesn't seem to have any, and in Singapore, there was none. Until very recently, with this new spike in the cases where we are now seeing about 2,000 to 3,000 cases every day, we finally in the last week have that I know of, 3 cases in NUH, myeloma patients that were COVID positive, so they were admitted to the hospital. Thankfully, they all seems to be doing well. And we're hoping to discharge them when they're COVID negative. But again, this was quite rare, and I think the association really depends on how prevalent the infection is in the community. Certainly now that it's more prevalent in the community, the likelihood will be higher. And also, what are the kind of protective measures that you take? And in Singapore, we all do a fairly good job with wearing masks and social distancing and following rules. So our incidence is way, way lower than these reported in US and Europe, where they don't really care so much about these safety measures, at least in the initial part of the infection. So now with the higher community cases, and we know that there may be cases in Singapore, myeloma patient, and the fact that we now have a new variant that is more infective, really we need to look at ways to protect our patients, right? So what are the methods that we have to protect our patients? The most effective and the cheapest, as mentioned earlier by earlier speaker, is actually the vaccine, right? And how does the vaccine really work? The vaccine takes advantage of our immune system, which by natural immunity, when we get an infection, we actually develop an immunity so that the next time we get that infection, we'll be protected, right? In a situation where we're encountering an infection for the first time, and this infection is a severe one, and we want to protect our people, then we want to trigger the immunity by using certain particles or the virus that we want to target without its ability to cause a clinical problem, right? So we either inactivate the virus so that it's no longer live, but it has all the proteins, the same shapes and so on that I showed earlier, so that it can trigger an immune response because it's foreign to our body. Or we want to utilize fragment of that virus, like the spike protein, or like the RNA that actually will produce that protein, right? To actually trigger the immunity in our body. And on this figure, I want you to pay attention on the immunity that it can trigger, right? So you see here the same thing, the virus, the spike protein, and we either use the virus or we use part of the component of the virus to actually trigger this immune response. And we see 2 types of immune response, right? The cell-mediated immune response that come from our T cells, which is a type of immune cells that we have in our body, and the antibody-mediated immunity that comes from our B cells. And in the earlier talks, particularly from Daryl, plasma cells, which are the cells that become cancerous in myeloma, are the cells that produces antibodies. So now you can see a potential problem in myeloma patients is that when we give our patients the vaccine, when they have very active disease where most of their antibody producing cells are abnormal, or when they are on very potent active treatment that's main purpose is to kill plasma cells, you will have an issue potentially with this process, right? So it's something to keep in mind, which is why, myeloma patients and the vaccine, there are some factors that we need to be mindful of, which I'll talk to you a bit more. But essentially, what we are trying to use here is either the whole virus or component of virus. When we use the whole virus, it will be not alive, so dead or inactivated, to trigger the immune response. The immune response require T cells, require B cells, particularly plasma cells, to produce either antibodies or the cytotoxic T cells that actually go and kill the virus or the viral particles. And because of this concept, there are different ways to deliver a vaccine. Okay, and this is a very busy site, but it follows the same schema, right? Virus, and then the antigen presentation, and then the immune response. And you can see that we can either use live virus that is somewhat a bit knocked down, so they're not fully awake, right? So attenuated. We don't ever use this in myeloma patients, particularly those with transplant, post-transplant, and so on, because this will cause problem. Inactivated vaccine, so this is no longer alive at all, but it's a whole virus, right? Or we actually replicate this virus in a vector, so it's no longer like the real virus. Virus is a vector, but we put in the RNA sequence, but it doesn't produces all the live protein that it is, right? So different methods, and then DNA vaccine. Only possible if it's a DNA virus. We are talking about RNA vaccine here because this is the RNA virus. So we put in the RNA from the virus that produces the spike protein, but doesn't produce all the rest of the important virus protein that cause infection, right? Virus is also very direct because after RNA is also direct because after RNA, it's the protein. Right, so it doesn't need to go in and out of the cells and do funny things. It straight away produces the spike protein that trigger the immune response. And also subunit vaccines are actually the subunit of the protein that is needed to produce an immune response. So different ways to take advantage of the general schema, right? And I just box here, these are the main ones that are present for COVID-19. The RNA vaccine that everyone knows about, most of us would have an RNA vaccine already given. These are the Pfizer, BioNTech, and the Moderna vaccine. But there are also others, right, that has been produced. So for example, the inactivated vaccine, the Sinopharm from China one. The non-replicating virus, the AstraZeneca, Oxford vaccine, not in Singapore yet. The subunit vaccine, the Novavax, which again is not yet available in Singapore. And you can see that some of these technology has been well utilized against other viruses, right? Subunit vaccine is commonly used for hepatitis B. So, we all have hepatitis B injection. So this is not a new technology. For the non-replicating virus, we have people have used it for Ebola, so not relevant to Singapore, but it's not a new technology. Inactivated vaccine, we use it for polio. All our kids have polio vaccination, so this is by no means new at all. So people were very concerned initially with the RNA vaccine because it is truly very new, right? There has been no prior use of RNA vaccine, but till now, millions of people has been vaccinated now with the RNA vaccine, and I think in general they have proved to be very safe and very well tolerated. Just to let everyone know, I just had my booster shot, third dose of the Pfizer vaccine on Tuesday. No problem at all. Today I'm talking to you like I'm fresh, right? This morning before this conference, I did a 1 hour walk to get my 10,000 steps, so no issue at all. All I had was maybe a bit of achiness on the day of the vaccine, but 24 hours later, completely back to normal. In graphical form, what are some of the differences? So like I said, technology are different. The dosing may be a bit different. For most of the vaccines, 2 doses. J&J is a bit special, 1 dose only. But you'll come to know later that, when we talk about 1 dose, 2 dose, there is always a difference in the efficacy and how much it stimulates an immune response, right? So you can see here for J&J, 1 dose, it is considered enough because it generates a high enough effectiveness, 72%, but you compare to the rest, is actually lower. And in fact, studies have shown that if you give a 2nd dose of the J&J vaccine, this goes up to 90-something%, right? So the dosing itself, I would say, is not really a critical. Now we're looking at 3rd dose for booster. For immune compromised patients, in fact, their usual regimen is now considered 3 dose, and the booster will be a 4th dose. In the future, it may be like flu vaccine, where every year we need to get a seasonal flu vaccine and so on, right? So, the number of doses really is not critical anymore. I think the main thing is it going to give us protection and immunity, right? Also, you look at how many patients have been studied before the vaccines are approved. It's variable. Some are higher, some are less, but in average, more than 40,000 patients before the vaccines get approved. The storage condition, these are more for people who deals with logistics, are also a bit different. The effectiveness is different, but in general, those that are approved in Singapore and available are more than 90% efficacy. This is based on the original version of the virus, right? With the Delta, I'll show data later that the effectiveness is all a bit lower, right? And so on. So just for information, the ones that are available in Singapore, Pfizer, Moderna, Sinovac is available through private channel, and I think there are others that increasingly over the next year or so maybe become available as well. There's some of them that have some unique issues, like the viral vector vaccine seems to cause increased incidence of blood clot, right? And we all know famously the mRNA vaccine may cause myocarditis, heart problem, particularly in young people, if they do rigorous exercise. So now with the appropriate advisory, we are not seeing so much of that anymore, right? So it's all sometimes for new product is a learning curve. Just like when we start to use daratumumab, there are some things that we have to deal with. Again, so there's a natural fear, but after a while, you realize that it's no big deal, right? So why do we want to get vaccinated? Is to reduce the risk of infection. Number one, people get disappointed and say, hey, how come we read in a newspaper that when you get vaccinated, you still get an infection? Yeah, the key thing is that it's not 100% protection, right? But the important point is the second point. If you're vaccinated, even if you get the infection, the infection is very mild, right? And I will show a graph from Straits Time later. We all get worried about the 3,000 cases every month or every day and all those things. But you look down at the graph, the number of cases in ICU is very stable and below 50, right? I mean, you look at the percentage. So it precisely is because more than 84% of the population is now fully vaccinated, right? And the fully vaccinated part is also important. If you just have one dose, your immunity is not going to be good enough. And so we do have people that get severe infection if they have only had one dose, right? So this is an important message. And really, should I get vaccinated? The question is always a risk-benefit ratio, right? There is a potential risk because, I may get some side effects from the vaccine and so on, but I would say that this risk is very low, right? For myeloma patients, there is no increased risk from the vaccination itself. You're not going to get more side effects or something from the vaccination. And also, we now know so many people are vaccinated. The risk of vaccination is really extremely low. The other risk you want to look at is the risk of infection, right? In 1 year ago, when you asked me, when I give this talk, I think earlier in the year, I did say that the risk of infection, because community cases are so low at that time, is very low, right? So people may want to weigh that, right? Depending on their work, their daily activity, and so on, whether it's truly needed, particularly if they're on active phase of treatment and so on, they may want to wait a bit until they're on maintenance treatment to get the vaccine. But today, the situation is quite different. The risk of infection is high because community cases are so high, right? So this balance, again, may shift, right? And then the benefit clearly is the vaccine response. But in myeloma patients, this is something that we want to be mindful of because the benefit of the vaccination may not be as high as benefit in a normal population, right? So this is where the booster and all those things become extremely important. What does MOH say? Everyone go for vaccination now, even if you have a weakened immune system, immunocompromised, low platelet. This was in the past, but even now, these types of patients can go for vaccine as long as their oncologists approve it, right? And I think there was a question raised earlier. People get turned away by the vaccine center. It's true, because if you don't fulfill all their common checklists, it may be problematic. And they'll ask you, have you asked your doctor? Is there a memo from the doctor that says you're okay? I would say that for cancer patients, myeloma patients, it's actually, in fact, easier to get the vaccination done in the hospital where they are treated. I'm not sure about the private practice, and maybe Daryl can say a bit about that later on. But in the public institutions, we all have vaccine center in the hospital now. So it's easier for the myeloma patients to actually get their doctor to sign off on a form, and then they go to the vaccine center in the hospital the next time they come for their appointments or something to get the vaccination. It's easy, it's quick, and there will be less question asked. Now, we all ask our patients to go for vaccine now, but does the vaccine work as well as the normal people? So these are some studies that were published in the last few months, also presented at the most recent International Myeloma Workshop. And I'll share with you some of these things. For some of you, the graph may be difficult to interpret, but let me zoom you in on the key points to note here, right? So this is a study looking at myeloma. MM is myeloma patients. All these are different myeloma patients and their antibody response after vaccination. This is control. Control means normal, non-myeloma people. And the key thing you want to look at is this line, okay? Because this is the average. And you can see that clearly for myeloma patients, although there's a big spread, some people get very, very good response up here. Some people get zero response down here. But on the average, the myeloma patient's response is less good than normal, right? And it's quite a lot of difference, you know, because here you look at the scale is 100 to 1000. So anything below 250 is generally considered not very good response, right? So we have more than half myeloma patients with not fantastic response compared to the normal people. And here you can also see a different graph. Again, same kind of dot and line, but you can see here is myeloma, MGUS, smoldering. MGUS and smoldering myeloma patients are those that are not necessarily on active treatment and have very low disease burden. So they are by and large more like normal people than myeloma people. This is the first part of it is day one when you get the vaccination. So clearly, you know, you don't expect suddenly the day one inhibition to be very good, but you will see that at 22 days, at 60 days after the second dose, you should see the immunity going up, right? And same for myeloma patients, you do see it going up, but in general, again, you see that the line is below that of the MGUS and smoldering. MGUS is most like normal people, so you get the highest. Smoldering is between MGUS and myeloma, so you get in the middle, right? So myeloma patients do not, on average, get as good a response as normal people. So but we see some people doing very well. So what are the factors that may affect that? The type of treatment that you have is an important factor. And you can see here that is very relevant to myeloma patients in Singapore is anti-CD38 daratumumab. The patients that are on daratumumab treatment have the poorest response, right? Compared to those on all other treatment and no active treatment. So you see that all other treatment and no active treatment, very similar. The line again, the average, very similar, right? But anti-CD38 is significantly lower. BCMA targeted treatment, just in case there are some of you out on this call that are not from Singapore and so on, that have maybe been treated with CAR T. CAR T is one form of BCMA targeted treatment for myeloma. This group of patients also have very poor response, right? So this is something to note. Other factors include when you are lymphopenic. So what is this? This is when you look at your full blood count and you look at the percentage of lymphocytes. There is a specific category. I don't want everyone to scramble back to start to look at their blood test reports now, but you know, you can do that at your own free time. But lymphopenia, severe lymphopenia while you're on treatment will actually limit again your response and so on. But the most important factor is actually what treatment you have, right? What treatment that you have. Lymphopenia, in fact, is a bit weak, is not significant statistically. right? And others are really not significant. So, really what treatment are we getting? And also, the age is another factor, right? The response is correlated with age. If you're a younger person, your neutralizing antibody response will be good. If you're older, it will be less good, right? So in myeloma patients, a bit of a double whammy, because myeloma patients generally are older as well, right? So this is in normal population. What about in myeloma patient? Is that also true? Yes, if you look at younger than 68 years old or older than 68-year-old, the older patients' response, again, you look at this thick black line, which is the average, is lower, right, than the younger patients. And then what about how long does the immunity last if I do get immunity, right? So this is also very interesting. This is in myeloma patients. You can see that the first one at the top are myeloma patients who had previously developed COVID, okay? Myeloma patients that never had COVID, and then a healthy people, this is in gray, and then healthy people with COVID in gray, and then healthy people without COVID at the bottom, right? You can see that if you're a healthy person without COVID, with a vaccine, it lasts at least up to five months, which is why the booster is recommended at 6 months and later. Same thing for healthy control who had previous COVID and recovered, because they already have some natural immunity. If you give the vaccine, this will actually last a long time as well, up to 6 months and more, right? In myeloma patients, you can see that, first of all, they don't get as high a response, but very quickly by 3rd month, they tail off down to almost like, before they get vaccinated, okay? Which is why for immunocompromised patients, we may want to give them booster even earlier, right? Not until after 6 months. But if you have had previous COVID-19, in fact, you have very good response to the vaccination, and this is long lasting, which is why I think partly, I'm telling people also that if you're vaccinated, don't panic if you get a COVID-19 infection. My mom is just for open disclosure, my mom is actually also a cancer patient undergoing treatment. She gets into such a frenzy, every time she hears news of someone is infection, and she's locking herself up in a room, and then not letting her go out, and then it's like, what to do, your dad is in contact with this and so on. I'm saying that don't worry, you're vaccinated fully. It's not so bad to get the infection actually as a person, because you will have mild infection, recover, and your immunity, it actually helps you strengthen the immunity. And so as we open up and our people in the population get infected, it's not such a bad thing as well, because the population will get what we call herd immunity, and with a high vaccination rate, actually make our country much more resilient and robust against the COVID infection. But I think the point here is that if you haven't, and we are naive, and because we are protecting our population so well for so many months, we will have many people that don't have COVID that may be having vaccination. And I think for myeloma patient, the important point is that the booster need to come earlier, right? And people are saying that, oh, don't worry, the antibody response not much. Don't worry, we still have T cells, because myeloma is only a B cell problem. Our T cells are going to be, very good, right? We have a T cell immunity. Remember, I told you that there's 2 parts of the immunity pathway. One is B and one is T. Sad to say, in myeloma patients, because of the type of treatment and so on that we give, steroids and so on, the T cell response are also not great, right? You can see down here. So I think it's important that we get our patients the right protection. I want to mention lastly, briefly about the different mutations. Now, the pandemic is mainly the Delta. This is a much more potent. That means the infection spread faster, right? The disease severity, is also a bit more significant. Incubation period is shorter, so your quarantine period is also a bit shorter now, and it's spread fast, right? So we have a lot of community cases now. Does the vaccine work? the vaccine still works. It is not perhaps as good as the pre-Delta, but nevertheless, it still worked, which is why the booster is important, because with the booster, this will go up back to the 80-something%, right? Which is why the government is rolling out the booster for the Delta variant. And for myeloma, does the third dose work? Very important, the third dose. You can see that the third dose can boost our immunity up by such a high percentage, right? So all myeloma patients should go for the booster shot if possible. Do not hesitate now anymore. So in summary, the specific advice for myeloma patients is that you should go for your vaccination. If you're not on active treatment and you're just on monitoring, no question asked, definitely go for vaccination. If you're on very active treatment, especially with the daratumumab and so on, if we can hold it a bit, go down to the treatment phase where you're on monthly treatment, it may be more effective, right? In the meantime, try to find other ways to reduce the risk of infection. But even those that are maybe because of work or whatever reason that really wants to have the infection, then we have to see how we can manage that during that time. The weekly phase will make it very challenging to give the vaccination, but the 2 weekly, we have some room to play around with. If you're on maintenance, there's no need to stop treatment, just carry on, continue with the vaccine. If you had a prior COVID-19 infection, not a bad thing, but you can vaccinate 90 days later. If you are post-transplant, vaccinate 3 months after the transplant, similar time frame for CAR-T. If you are pre-transplant, try to do your vaccination before your harvesting so that all your 2 doses are done before you go in for your transplant treatment. If you're on active, if you have active disease and are active treatment, you can actually receive the vaccination except for certain exclusion. If your blood count is very low, you're severely neutropenic, then the vaccine may not be very effective during that phase as well. So you may want to wait for the blood count to recover. Choose the time frame, the timing is what I say. Have a good discussion with your physician to plan this together. You don't have to, again, panic and worry about, can I do this? Should I go? Do it in the hospital in concert with planning with your physician. But last thing is that we all know myeloma patients, the protection will not be as good as normal people. No matter what we do, also remain vigilant. Don't just feel that I'm a vaccinated person, then I go out shopping every day, go and mix with all sorts of people every day, just go wild. No, be measured in our daily living and what we do, but also do not lock yourself up and think that I cannot lead a normal life and do things when I need to as well. But take the necessary precaution. Life have to go on and be measured, in what we do, because there is a lot of community cases out there now. So the risk of infection, particularly for those that are not vaccinated, is high. But I want to draw your attention to this yellow bar down here, which is those people in ICU is very, very low. Those who are vaccinated and in ICU is even lower. So go and get yourself vaccinated and protect yourself is the key message here. Okay, with that, thank you very much. I think actually I've taken so much time. I'm not sure whether we have time for the live Q&A. I think we should do that. I think if our colleagues don't have to rush off, we should maybe still spend about 20 minutes or so with the Q&A.
Okay,
is that okay with you, Daryl and Molly?
Yeah, absolutely fine. No problem.
Thank you, Professor Chng. So now we will start with our live Q&A sessions. Okay. So there are quite a number of questions from all of you. Thank you very much. In the interest of time, we might not be able to answer everything. Some of them, the answer has been typed out, as you can see in the Q&A box, and we'll answer some of the questions live. So the first question is multiple myeloma a curable cancer today?
I can go first, and then maybe the others can chip in. Unfortunately, we can't say that it is a curable cancer. Over the last 20 years, I think the developments in the different medicines that as myeloma patients and doctors we have received from the amount of research that has gone into this field has brought it much closer, though, that we are able to even hope that one day it can become a curable cancer. That said, in a smaller proportion, over the last 5 to 10 years, we do see increasingly patients remaining in that quiescent phase of myeloma for a very long time. So if we look at the international group of myeloma doctors, they refer this condition or state as a functional cure. What that means is there is still a propensity for these patients, maybe 5, even 10, 15 years later, they can potentially still come back with a myeloma, but these are patients that can potentially remain in that quiescent phase for a very, very long time. And that has only been made possible with the different newer medications like daratumumab, bortezomib, and lenalidomide, and all the rest of the other new medicines, including the CAR-Ts that have come on. But as of now, we still see the relapses happening regularly for the vast majority of patients.
Thank you, Dr. Mouli. Is there any other additional input? Or in the interest of time, maybe we move on to the next question first. So the second question, one of our participants commenting that they would like to know more about how is the treatment for transplant eligible patients. And also we can combine it with the other questions with the current COVID situation, is it a good advice to do a transplant now, or is it should we postpone it for now, and how is the approach for now?
Should I answer that question? I think, like I said, it's a risk-benefit ratio. The important thing about transplant and myeloma that I think it's good for people to generally know as well is that, in fact, for myeloma patients, if you do an upfront transplant versus if you transplant at first relapse, the outcome has not been shown to be very different. So it's not always a must to do transplant at diagnosis, right? But there's no doubt that transplant does improve outcomes for our patients. That's one thing to say. The only reason why we always suggest patients do transplant up front is because, at relapse, it's unpredictable, right? I mean, you may well become a non-transplant eligible patient at relapse because you have a kidney problem or you have some other issues. So you may lose that benefit from the transplant. And as I said earlier, the whole thing about what we do with therapy and vaccine and all these things is really a risk-benefit ratio. There is no, you must do this, you cannot do that, because we are all talking about, how to minimize risk and maximize benefit, right? So if for some reason you are not vaccinated and you are in a situation maybe now where the pandemic is raging, there's a lot of cases that you have concerns about this, then we can well delay your transplant till later. So I think that's one aspect. But if you already are vaccinated, then you can still undergo the transplant. There's no reason why you can't, and then we can give you the booster or after that, right? So I think it depends on individual situation. I will encourage patients to discuss their own individual situation and measure and look at this risk and benefit with their doctors, and then make the decision in the end. So, but the key point here is that I don't think you necessarily must do the transplant up front. You can always potentially delay it as well. Again, depend a lot on your response to your other treatment. If your induction treatment is going very well, the response is very good, what we may want to do is collect your stem cells, at least we know you have healthy stem cells kept away, and then delay your transplant. So that's always possible. But if your induction treatment is maybe not going great, your response is not very deep, then maybe the benefit of the upfront transplant will be greater, right? That we need to do it now. So there is a lot of individual situations that is probably difficult for us to go through all the scenarios, but I will encourage you to speak to your doctor.
Thank you, Professor Chng. The next question, when do patients switch from 1 monthly dose of bone targeting agent to once every 3 months? Is there any guidelines, or what is the usual practice?
So maybe I can answer the question. So recently there was a study that showed that monthly use of Zometa is as good as every 3 monthly. But by and large, when we see patients with very bad bone disease like diagnosis, I would probably still give monthly doses of Zometa. Right now, there's an alternative called Xgeva, which we can give as well. However, when the disease is way better in control, when the disease is in remission, I could actually switch it to 3 monthly. But in the beginning, we usually try to give monthly, but later on, we switch to 3 monthly dosing of Zometa or Xgeva.
Thank you, Dr. Daryl. The next question is directed to Dr. Daryl, is about that we can eliminate autologous transplant when patient reach MRD negative. So one of the participants has a concern, like her husband is planned for transplant in December, but her numbers are all doing very good. So is there a way to say that whether he really needs a transplant or can do without the transplant and will go to long-term remission?
Right. Sure. I'm glad Rakesh asked this question, because right now I must qualify that MRD, we still do not use MRD to inform treatment decision. It's still not prime time yet to assess MRD and decide whether the patient needs to go for transplant or not, because MRD is good, but you have to have a sustained MRD negativity, right, for the best outcomes, because you could be MRD negative now, but 1 month later you could be MRD positive. So one way to maintain your MRD negative status is actually to go for transplant. It could bring the disease even lower. By and large, transplant is still one of the most cost-effective ways to treat. Even when we measure the bone marrow and its MRD negative before a transplant, sometimes the MRD measurement is not uniform throughout. So I could say that the lab could say that we do not detect a myeloma cell after counting 100,000 cells. But actually, if you count 1 million cells, you can still detect a myeloma cell. So we do not use that information to decide on transplant. As it is now, there are many clinical trials to answer this question, to determine if we can use MRD status to determine if a patient needs to go for a transplant, but this is still not ready for prime time. We still advise patients to go for stem cell transplant, especially if they're young and they are fit, because it has been, this is a time-proven procedure that transplant can control the disease for a long time to come.
Thank you, Dr. Daryl. There are a number of questions with about the COVID vaccination in myeloma. So I think maybe people want to clarify about the booster jab for myeloma patients, like when to get that and what kind of vaccine, and maybe what is the thought about that.
Yeah, so I've tried to answer a few online, but indeed there's quite a lot, right? So maybe I can address them generally here. Again, I will encourage generally myeloma patients to get their vaccine done in the institution. So have a discussion with your doctor, make sure the timing of your vaccine is at the right phase of your treatment and it's appropriate, so that you won't run into problem. Because the problem is you go to a vaccine center in a community, they will ask a lot of questions, you'll probably be turned back. In terms of the booster, so because it's done in a hospital with the approval of your doctor, you don't have to follow the general rule of 6 months later and so on. So I've given a few patients the booster after 4 months, 3 month plus. There is no issue, right? So that's okay. Number two is that for the booster, if it's at the present time, at least, if it's an mRNA vaccine, if you want to switch from Moderna to Pfizer, there is no issue as well. If you want to switch to Sinovac, I'm not so sure, but in some patients that have some problem with earlier vaccine dose, like some side effects and so on, that they're not good, right? Then actually switching to a different form of the vaccine like Sinovac is an option for them. So I think in general is speak to your doctor. In fact, it's probably dangerous for you to decide yourself when to have the vaccine and go to a vaccine center and get it done. Definitely speak to your doctor and plan the timing of the vaccine carefully with them.
Thank you, Professor Chng. In the interest of time, we have now come to the end of the forum. Before we end this session, NCIS would like to share some upcoming events. As everyone knows, October is Breast Cancer Awareness Month, and we would like to encourage you and your loved ones to participate in the breast cancer activities lineup for you, and also a reminder to go for a screening, or even buddy up and accompany your loved ones for their mammogram appointments. You can see the further details on your screen. So please join us for these important events. Next, NCIS will also be hosting the Singapore Geriatric Cancer Symposium on 13th of November. More details are available on our website, www.ncis.com.sg, or our NCIS Facebook page. Before you leave, please help us to complete the event feedback form. It will only take 2 to 3 minutes of your time. You can either scan the QR code on the screen, or you will be automatically directed to the feedback form once you leave this webinar. We have also prepared a special participation gift for myeloma patients. The kit has a treatment organizer, stress ball, exercise band, a water tumbler, and a pouch. Please kindly include your address when completing the feedback form so that this can be mailed to you after the event. We have now come to the end of the session, and we would like to thank you for your participation and support. We would also like to thank again Professor Chng, Dr. Alison Soh, Dr. Chandramouli Nagarajan, Dr. Daryl Tan for giving us an insightful presentation, and our sponsor, Amgen Biotechnology Singapore. We hope you have enjoyed today's webinar. Thank you and have a nice day.